Okay. Yeah.
Dave, do you want to kick us off? You want me to start?
Yeah, well, thanks for joining us again today, folks, for another talk with Dr. Leichliter. I know Bud and Judy, it sounds like this is your first time. So if you are new, find the chat box on the screen. And if you'd like to ask Dr. Leichliter a question, just type it into the chat box. But I'm going to mute everyone because we get a lot of background noise and it gets a little, it interrupts a bit. So.
Oh, come on, people.
You have the ability to mute everybody, David? I'm not entirely sure we can. I feel like everybody has to mute themselves.
Well, if you can mute your.
That might have worked. Well, and
I
actually,
took care of that.
that was perfect. See, thanks, Christine. You know, I can't use this stuff. So I was actually going to start by David. I'm glad you're on because Google remembers everything. Once you put something into a Google Calendar, if you put it on repeat, it remembers everything forever. And sure enough, today is the anniversary of the first day we had a Parkinson's disease clinic back in 2016, March 3rd. And so again, we were the first ones there. You know, it's been a while and it's been an interesting journey for us, but happy anniversary to us. Well, welcome to everybody to the party. I'm Dr. Leichliter. I'm a neurologist and theoretically I'm a movement disorder specialist, or at least that's what I like to tell everybody, which means I specialize in Parkinson's disease. For those of you who know me, welcome back. For those of you who don't, welcome to the party. I like to start off with a couple of things. Two things I like to kind of remind people of is the first one is everything you hear is my opinion. You may go to a different neurologist, you may go to a different movement disorder specialist. They may have a different opinion or sets of opinions. And so everything I'm telling you is just my opinion. I like to think my opinion is based on the best data that we have, although sometimes I do have to make stuff up, in which case I usually throw up some quotation marks to let you know that I'm making stuff up. But even when I try to make stuff up, I try to make it as scientifically sound as I can. The other thing I like to say is that this is not a great forum for specific medication adjustments or specific care. Even if you're my patient, it's not the best place to say, hey, I'm doing this, this, and this. I'm on this medicine. I'm having a problem. What do you think I should do next? As you'll hear, there's definitely some general themes to my answering of questions. And one of them is, hey, you should really have good communication with your doctor. If it's me, send me a message, preferably in our computer system. If it's your own doctor or somebody other than me, get a message to them, a phone call, a direct message on the computer, but keep an open line of communication and they can tell you what to do. With that being said, I'm going to get started with some questions. And like David said, the best place to throw the questions is down in the chat box. It'll show up on my screen and I'll kind of pick them off one by one. Again, if you are, even if you're not new, if you're a returning visitor, thanks for coming back. Feel free to throw up questions that I may have answered in previous sessions because there's always new people. There's always different perspectives. It never hurts to hear this. So don't be afraid to throw out a question just because you think I've covered it before. Believe me, and don't be afraid to throw out a question in general. Everybody has a lot of questions. If you have a question, most likely somebody else in the audience probably has the same question. Definitely feel free to ask. I did get a couple of emailed questions. One I thought was actually was kind of a whole list of questions. Let me go back to my email here. Here it is. There we go. So it was an interesting, and it's something I don't think I've talked about before. So the question was, can you go in depth about internal tremors? And so internal tremors are an interesting phenomenon that I run into not infrequently. So a lot of patients come in with the outward tremors, right? You can see it, your hand is shaking, your head is shaking, your legs are shaking, whatever. But it's actually not uncommon for people to have what I don't think I made it up, but somebody called an internal tremor, which is exactly what it sounds like. You really feel like you're shaking on the inside, although there may be, but there might not actually be any visible outward tremor. And a lot of people feel it in their chest. A lot of people feel it if it's cold outside. So a lot like all the other tremors that you can see. It's worse if you're nervous. It's worse if you're cold. It's worse if you're upset or anxious. But again, just because you can't see it doesn't mean it isn't real. The internal tremor is actually fairly common. And then there was the question of whether or not it can interfere with speech. And so I think this might actually be a couple different things. So internal tremors can progress as the disease progresses. They can sort of correlate with visible tremor, so that's not uncommon either. And it doesn't necessarily go with beginning, early, medium, late stage of disease. It can happen anytime. Medications sometimes work for internal tremors, just like they work for external tremors. And really, you would aim for it the same with the medicines that we would use for an external tremor. But then they started asking about, can it interfere with speech, breathing issues, things like that. And so I wonder if there's actually a couple different things here. So an internal tremor feels like an internal shaking, but you can actually get a dyskinesia internal, or what I more commonly see when it interferes with speaking and breathing is a ventilatory dyskinesia. And so that would actually be a side effect of the medicine. So just like you can get a dyskinesia outwardly, you can get an internal dyskinesia as well. And that's what I've seen more commonly be impactful for breathing, speech, things like that. So a lot of people, I wouldn't say a lot, some people come in and they say, I just feel short of breath. And then they go to their PCP and they have all the heart and lung workup and it's all normal, but they just feel like they can't breathe. Their oxygen saturations don't go down. They are breathing, but they feel very short of breath and it's very irritating. And that is not an uncommon thing for a ventilatory dyskinesia. So if you can pattern this with medications, if it's when your medicine is at its peak, you have this shortness of breath, it's possible that it could be a side effect of the medicine. So I wonder if you're actually asking about two different things with that line of questioning. But the short answer is yes, internal tremors happen. They're not uncommon. I treat them generally just like I do an outward tremor. If they're bad enough, we try the same medicines. Tremors themselves don't generally impact breathing, although you can get a voice tremor as well, so it can impact voice. But what I usually see impacting breathing is more of a ventilatory dyskinesia. The other question I got was actually from one of my patients doing what they're not supposed to do, which was asking about Comtan, and it was making them a little bit sicker. And the short answer is, we should talk about it, but if a medicine is causing you a side effect, then really the end result is going to be that we should get you off of it, or at least kind of taper it down the way you tapered it up. And that's usually how, if you're my patient, if I'm adding a medicine, you'll find I don't usually just add a lot of medicine. I don't usually just have you just stop a lot of medicine. You kind of have to work your way up, work your way down. That's usually the best way to do it. So again, if you are having side effects to your medicines, you should definitely talk to your doctor. You should definitely have good communication with your doctor, although I recognize communication in my office is not always the best. I am well aware of that fact. Phone calls to my office are, we'll just say, bad. Messaging is a little bit better, but even then still iffy. But yes, trying to communicate with your doctor is the best choice. But tapering up and down on medicines is usually the best way to do it. I actually like this question. So now I'm going over to the chat. So again, feel free to throw your chat questions in there. At the end of the day, I'm going to start at the top and work my way to the bottom. I got a cup of tea, so hopefully my voice will hold up and we'll just go from there. What about boxing? Just the actions, or is the contact with gloves better for exercise? Well, I would not recommend getting punched in the face, if that's what you're asking. Getting knocked out, not exactly the best plan for the brain. Even any kind of repeated hits to the head, generally not a great plan. But that being said, I don't know that there's anything special about the contact to it or actually boxing versus just going through the exercise. And believe it or not, my opinion really is that there's not a whole, and half the group on here might freak out when I say this, there's not actually anything magical about boxing. I know this sound, you're like, wait a second, the boxing class is great. You tell me to go box. I love it. It's working. What do you mean? What do you mean? It's not, there's never been one exercise compared to another that's better. All exercise is good exercise, and exercise, as you guys know, if you've been on here long enough, is or if you're my patient, is my absolute favorite thing to talk about. It's my absolute favorite medication or treatment strategy. I love everything about exercise. There's nothing special about boxing other than it's fun everybody there has a similar thing, so it doubles as a support group. And people generally like to do it. And what you'll find, and everybody here knows, if you enjoy doing it, you'll be much more likely to keep doing it. And the key to exercise is consistency. You know, as much and as consistent as you can do is going to be the thing that helps you out the most. And since exercise is the only thing that we think is disease modifying today, it really is super important that every single person on this call, those with Parkinson's disease and those without Parkinson's disease, start exercising. It is the key to success. But I don't think there's any one exercise that is necessarily better than another. I have patients that absolutely hate boxing or hate the boxing class. And I say, well, then don't go. I mean, again, there's nothing that says boxing is any better than getting on a stationary bike, swimming, dancing, getting on a treadmill, doing something else that gets your heart rate up. The benefits to boxing are maybe they do work on balance a little bit more than just a treadmill or a stationary bike, so that's helpful. And people really enjoy it, so they keep going. Again, coming back to the question, I really wouldn't recommend that you get beat up trying to do better from an exercise standpoint, unless you're a really good boxer and you like it, go for it. But just doing the exercises really is the key to success, and doing them consistently is really important. I've been having a lot of problems with my eyes. I was told that my brain is not registering to the orbital nerve. My vision will be blurry at times. It will be wonderful at times. My eyes don't open when I wake up, like they're glued shut. There's a whole lot going on in that one. And so vision is tough. As I will always tell you, and basically tell everybody that I talk to or comes to me or questions it, every single thing you can think of can be a symptom of Parkinson's disease. Parkinson's disease affects every single system in your body, every single organ in your body to some extent. And so I get a lot of questions. Can vision be affected in Parkinson's disease? Can urinary problems, can sleep problems, can mood problems, can you name it problems be a side effect of Parkinson's disease? And the answer is always yes. Parkinson's disease can affect every single organ system, every single sense. And vision is no different. And I get a lot of patients that say my vision fluctuates throughout the day. I get blurry vision, I get double vision. And it's a really hard problem to fix, because everybody goes to their eye doctor, and their eye doctor does their fancy things with all the glasses and the refracting things that get your vision perfectly. And they say, oh, I fixed your vision, and they give you new glasses. And then you get home and you say, wait a second, I can't see again. It worked so well when I was in the office, and now my vision is blurry again. And it's because the vision problems in Parkinson's disease fluctuate so much. So just like all your other symptoms fluctuate, right? Your stiffness, your tremors, your mood, your sleep, your everything, your GI system, it fluctuates. It fluctuates sometimes throughout the day, multiple times a day. The vision problems fluctuate too. And they don't always respond to medicine the way that tremors or stiffness does. And so vision problems in Parkinson's disease are a big issue. And they're not easily fixed with medications, and they're not easily fixed by going and getting new glasses. It is something that we try to work on. We try to adjust medicines for. We try to see what we can do, but it is a challenging problem. The other problem that you mentioned on there, that your eyes won't open. So that sounds more like either a lydipraxia or a blepharospasm, which can also go along with Parkinson's disease. And that becomes a little bit more of a challenge. Now, it's a little bit tough to figure out based on that what's going on. But so say, for instance, if your medications are wearing off overnight, maybe we need to adjust something so that you're carried through the night, so your eyes feel better when you wake up in the morning. If it's just that your eyes are shut, either they're squeezed shut or they just can't open them, and it has nothing to do with medicines, then it may just be something we just have to live with and work on. Again, another problem that's not easy to fix, but also paying attention to, is it related to medications wearing off, things like that might help us if we want to try treating it a little bit better, or if there's a way. I started a rock steady boxing and I feel like I have more energy. Is it possible that it's improving my PD? Absolutely. So again, exercise is the best. And interestingly enough, the number one complaint that I get walking in the door every day, 15 times a day, is fatigue. Every single patient that I have is tired. Every single patient that I have is dragging. Every single patient that I have has a lack of motivation, a difficulty pushing themselves, an overwhelming sense of fatigue. And I have a lot of theories on this. My best idea or my best theory is that Parkinson's disease is just tiring. It's hard. It takes a lot of brain power to think about every single thing that you have to do. Again, patients with Parkinson's disease can do anything, right? You can take big steps. You can talk at a loud voice. You can swing your arms when you walk. You can control your tremors, but you have to think about it, right? I don't have to think about that, thankfully, at least not at this point. I can walk down the hall and my arms swing just fine. I don't think about taking big steps. I don't think about swinging my arms. And when you have to stop and think about every little thing that you want to do, this is really fatiguing and really tiring. And my personal opinion is that the tiredness that people with Parkinson's disease get is a mental fatigue. It comes from that constant need for thinking about every little thing, more so than a physical tired. I don't get a lot of people that say, hey, I feel like I just ran a marathon and I'm physically tired. It's more of a mental fatigue and a mental tiredness. Why that's important is fatigue is also the thing I'm the least good at fixing. And I've tried just about everything. You name it, I've probably tried it in a patient somewhere. I've tried more Cinemet. I've tried other dopamine medicines. I've tried caffeine. I've tried just saying, hey, have a couple extra cups of coffee. I've tried stimulants. I've tried antidepressants. I've tried working on dopamine, serotonin, epinephrine, norepinephrine. You name a chemical that's in your brain, I've probably tried working on it on somebody. And I have had very little success treating fatigue and tiredness in Parkinson's disease. And to circle all the way back, because that was a very long-winded answer to a very short question, the only thing that I have consistently found to give people energy, to treat that fatigue, to really make people feel better is exercise. Again, you're going to get tired of hearing me say exercise because it's my absolute favorite thing and I love talking about it, but it's because it's such a good treatment. It really does make every single person who does it feel better. They have more energy. It's the only thing that we think is disease modifying in Parkinson's disease, meaning we think it slows down your disease course, and the medicines don't do that. The medicines treat your symptoms. Exercise treats your disease. That's the end of my current talk about exercise. However, I'll probably circle back 3 more times before the end of the conversation. I do We Fit for exercise. I love it. I highly recommend it. Great idea. I actually have a patient who has an Oculus. So the virtual reality is becoming a great tool these days. They're using it in rehab. They're using it in spine injuries, in brain injuries, in stroke. I think it's only a matter of time until we really look at this or start using it in Parkinson's disease of the neurodegenerative conditions. They have to be a little bit careful because I don't know if you've ever tried on the goggles, which is basically virtual reality. You actually can't. I just bought this for my son. This is how I know he loves it. You actually can't see the room around you. And so while I think it's good exercise, everybody here has to be very careful because falling is not your friend. And so again, however you want to do your exercises, be my guest. They're all good. Have any of your patients who were vaccinated and boosted gotten COVID? If so, what were their outcomes? We have been very careful not socializing, even though we were triple vaccinated. I honestly don't know the answer to that question. I can't think of any patient that I have that came in and say, hey, not that I can think of offhand is the short answer. However, even though I can't tell you about my patients, although I do have a lot of people who come in and are definitely worse after they get COVID. I've had patients who are worse after the vaccines. Don't get me wrong. I still think everybody should get vaccinated, but I've seen patients who have had all the above. I can't think of anybody necessarily who said, hey, I was triple vaccinated. I still got COVID. This is what happened. Doesn't mean it didn't happen. It just means I can't remember it offhand. But my case in point for the vaccines is actually my own family. So I am triple vaccinated, I guess, probably quadruple as soon as they tell me I have to get another one. And I have 4 kids and I'm married. My wife was vaccinated but not boosted. My 3 older kids were vaccinated and my youngest is only 1, so he did not get vaccinated. The people that got the sickest were my son, who's not vaccinated. I'd say he was lethargic for a few days, had a runny nose, and my wife, who was not boosted. She lost her sense of smell. She had a sore throat. She had some illness for about a day or 2. The bigger kids who were vaccinated were just maybe 2 of them were like tired for a day. 1 of them didn't have anything. And then I was triple vaccinated. I didn't get any symptoms. And so again, is that just coincidence? Maybe. I like to think that it really went right along with vaccination status. Again, I don't have any stock in the vaccines by any means, but thankfully the numbers are going down. But for a while, we were taking care of a whole lot of COVID positive patients. And believe me, if you think the side effects of the vaccine are bad, getting COVID's not much, definitely not any better. That's just my opinion. My voice squeaks a lot with just a little bit of using any muscles, including my brain. Is this very common with Parkinson's? Well, sure. Speech is definitely affected. A lot of times I'll hear that my voice gets softer. I run words together. What I actually usually hear is my significant other can't hear. Not the case. It's not your wife's hearing. It's your voice, for future reference. And so a lot of voice changes can happen in Parkinson's. You can actually get a voice tremor, believe it or not. There's a lot of, you can get a tongue tremor. I've seen that too. You can actually get a lot of things that affect voice quality, voice production in Parkinson's disease. The best answer is actually speech therapy. So I'll send a lot of patients to speech therapy. This is why I have a speech therapist in my office who evaluates patients for me in the Parkinson's clinic. Because again, speech is something that's a little bit challenging to treat with medicines. If it does seem to fluctuate with your pills, such as your physical symptoms do, then sometimes more medicine helps. But a lot of times that voice problem or any voice changes are difficult to treat with medicines. And usually the best thing for that is speech therapy. Again, that's worth getting evaluated and at least worth looking at. The Parkinson's Foundation website lists Exelon as the only FDA-approved Parkinson's disease dementia medicine, but they also list Aricept and Razidine. Does this mean that Exelon is preferred for Parkinson's patients? I prefer it for 2 reasons. I'm actually not entirely sure which ones are approved, but that's partly because I do what I want and I don't really care what's approved by the FDA. At the end of the day, we use whatever we need to. My personal preference is Exelon. So this is rivastigmine. So Exelon, Aricept, these are all Alzheimer's disease medicines. Believe it or not, there was no medicine that was invented for dementia or kind of memory problems in Parkinson's disease. And so we steal a lot of our medicines from other conditions. And Alzheimer's disease is the one that all of these drugs were really invented for. I like Exelon better than Aricept, Namenda, galantamine, any of these other ones for 2 reasons. One is it probably has the best data. So at least at the last time I checked, I know there was a recent study that I read about Aricept in terms of both memory, but also walking and balance. But I think Exelon has better data. All the data in this is weak, by the way. There's not a lot of good data here. So this is definitely a little bit made up, although there is some data to suggest what I'm talking about is true. The little bit of data that there is was really first published in Exelon. Exelon was the drug they used. More recently, there is some in Aricept, but Exelon was the first one. So it has the best data, according to me. That's my opinion. The other reason I like Exelon is if we're lucky, it comes in a patch. And so I find that because most of my patients are on a lot of pills, it's nice to find a medicine that comes in a patch. You generally avoid the GI system, although upset stomach is still a side effect of it. I personally think that it's less than with the pills. The biggest reaction is a skin reaction, and it's easier. It's 1 a day. You put a patch on, you wear it all day, you wear it all night, you change it the next day. The reason why I specify if we're lucky is insurance companies don't always like to pay for patches. My guess is patches are more expensive than pills. Exelon does come in a pill. And so sometimes I run into insurance carriers who won't cover the patch and I have to switch to a pill. I still use Exelon over Aricept or Namenda, the other ones, but I like Exelon because it does come in the patch. I use Aricept, I use Namenda, I use galantamine, I use all of these medicines because at the end of the day, none of them are that great from a memory standpoint, from a dementia standpoint. And so we do keep trying to see if we can accomplish the goal. But the key to success with these medicines is knowing what the expectations are. And so particularly from a dementia or a memory standpoint. So none of these medicines really improve memory. And so I'm going to say that again, because this is really important for all the patients that come to me for dementia, for memory problems, for thinking problems, for cognitive problems, and we put on these medicines. And I try to stress this when you're in my office, but I'm not always good at expectation management either, believe it or not. None of these medicines make you think better or have been shown to make you think better. All of these medicines have really been shown to slow down the decline. So why is that important? It's important because you never really know if the medicines are working, right? And so the best way to think about this is if I'm doing a drug trial and I'm using Exelon, I can give, we'll say 500 people the medicine who have dementia, 500 people who we won't give the medicine to with dementia, and we'll see what happens, right? And then you can see a trend. You can say, okay, hey, look, these 500 people that I gave Exelon to, they tended to stay better than the people who didn't take Exelon. It must be doing something, right? And then you can get it approved and everybody's happy because you have a medicine that slows down disease, slows down the memory problems, or at least keeps you at the level that you're at. Now imagine how you measure that in any one person. You can't, right? You don't have anything to compare it to. We don't know what you would have been like if we didn't put you on the medicine. And again, these aren't medicines that are expected to make you think better. They're really trying to keep you at the level that you're at or slow it down from getting worse. And so this is always the problem that I have. I put people on Exelon or Aricept or Namenda. They come back 3 months, 4 months, 6 months, and they say, it's not working. My memory is getting worse. And I say, yeah, I know that. I can't fix that. And I don't know if the medicine's working because it wasn't supposed to make you better. It was supposed to try to slow you down from getting worse. And so you can understand the problem with trying to understand or recognize if any of these medicines are really working. And so that's one of the issues that we have with these medicines is we don't have a great medicine that really fixes memory problems, cognition, dementia. Again, coming back to the original question, is it the only one that works? Is it better? I don't know. I prefer it. That's probably why I go to it first for the reasons that I mentioned. But I also use the other medicines a lot. I honestly don't know which ones are FDA approved for it. So I'm not going to comment on that. But to me, FDA approval is not really that important. I use whatever medicines I think are the most effective, the best choice for patients, regardless if they're approved or not. And then I fight with insurances after that. Are you aware of any negative outcomes of DBS? That sounds like a really loaded question. I feel like I'm treading into dangerous water here. I understand that it may be successful or not in reducing PD symptoms, but I recently heard that it may have serious long-term side effects. That's a hard question to answer. I don't think that the deep brain stimulator itself has serious long-term side effects, but it also doesn't alter the progression or slow down the disease. And again, we're talking about a condition that gets worse over time. And so even if we do surgery for you, things are going to get worse over time. That's not a side effect of surgery. That's a side effect of having the disease. Are there negative outcomes? Well, yeah, it's brain surgery. There is not a single brain surgery out there that is risk-free. There's not a single medicine out there that's risk-free either. But there are potentially very bad consequences of DBS. Now, again, statistically, those chances are really low. But if they happen for you, it doesn't matter what statistics are. It still happens 100%. There are other things that the deep brain stimulator is good for, and there's other things that the deep brain stimulator is not good for. For those of you who aren't aware, we do brain surgery for Parkinson's disease. And the deep brain stimulator is one that we've been doing for about 20 years, where you put wires into somebody's brain, you hook them up internally to a generator in their chest, and it can electrically block signals and treat symptoms the way the medicines do. It is good for some of the things the medicines are good for, i.e. tremors and stiffness and slowness of movement. It is not good for some of the things medications are not good for, i.e. speech problems, cognitive problems, balance problems. And so there are some things to consider before you have brain surgery. And this is why DBS is such an individualized process, right? There's so many things so many factors that we consider when we're trying to decide if somebody's a good surgical candidate. Not just your age and your other healthcare comorbidities. Are you on blood thinners? Do you have a heart problem? Other surgical issues, but your Parkinson's symptoms. Do you have the right symptoms that DBS seems to be good for? Do you respond to medicines? Are you having problem with medicines? Do you have some of the things that might make us not want to do surgery, like some dementia or some memory problems? Again, these are all the things that we have to think of. I'm not entirely, again, coming back to the question, I'm not entirely aware of any serious long-term side effects just to having the surgery, but there are a lot of things that you have to think about before surgery. And that's just one of the long-term effects is just one of the things we have to consider. I knew somebody was going to throw this at me. Was I get tired and fatigued after doing exercise? I knew somebody was going to hit me with it. I was extremely fatigued after walking, walk class, silver sneakers, etc. Doing better after boxing, which is good. High intensity, and we work on balance reflexes. Absolutely. They're looking at high intensity exercise, and there's some evidence that high intensity is better than low intensity, but the data is iffy. And it's not great yet. It's not enough for me to say everybody should be doing high intense or HIIT therapy in general. Again, I just throw exercise out as a general rule of thumb. Everybody has to exercise. How you want to exercise, great. The more exercise you can do, the higher the intensity, maybe the better off you are. But at the end of the day, exercise is the key to success. And whatever it is you can do, whatever it is you enjoy doing, whatever it is you can do consistently, that's going to help you do the best. I do have patients who tell me after I exercise, I'm tired, I'm worn out. I have to take it easy the rest of the day. And that still happens. But at the end of the day, even though you kind of have this dip or up and down with exercise, the overarching benefit is tremendous, and you still have to do it. And generally, the rule of thumb is it does tend to give you more energy. And so even though you're tired thereafter that day, in general, it tends to increase energy and make you feel better. I personally think, and now this is my opinion, take this for a grain of salt. I personally think the best exercise is a combination of a bunch of things. I think you should do some high intensity exercise, but I also think you should do some Tai Chi and yoga. I think you should do some weightlifting or some resistance training to build muscle, but I also think you have to do some cardio. And I really think if you could, it's kind of like eating, right? Well-balanced diet's the best thing for you. So we think well-balanced exercise, I think is probably the best choice. There's no evidence for that. I completely made that up. But just logically, all of those affect the body differently, right? You definitely need muscles. You need muscular strength in your legs and core to stay upright, but you also need to work on your cardiovascular exercise. That's what really pumps blood to the brain, clears out debris, helps cell functions work better, gives you that energy. Tai Chi and yoga is great for calming things down, but not exactly great for getting your heart rate up. It's great for stretching. It's great for range of motion, right? All good things. But at the same time, higher intensity is the best way to get your blood pumping. And so I don't think I'm going out on a limb when I theoretically make up in my head that the best plan is a combination of all of these things. But the key to success for exercise is nothing special. It's just doing it. And so find something you like to do. If I tell you the best exercise in the world, the absolute best exercise in the world is the one you hate doing, you're not going to do it. Nobody's going to be able to maintain and consistently do something they hate. I don't expect you to. And so finding something you really do enjoy doing that's active, key to success. You don't like doing anything that's active, too bad. Find something you like to do. Make it up. The patient called with a lot of dyskinesia and asked if they should go to the emergency room. I don't think I would necessarily send somebody to the emergency room for something like that. But the general topic here is an important idea. So the key to success, and I know my office is hard to get into or hard to talk to. This is probably true for every other neurologist or every other doctor that's on the planet right now. None of us have enough help. We're all struggling just to make it. Let's just put it that way. And so it is hard to get messages in, it's hard to get answers, it's hard to get responses, but your best bet when something new happens is to touch base with your doctor. Again, if something abruptly changes like that, well, then we go looking for other stuff. Do you have a urinary tract infection? Do you have a pneumonia? Do you have an electrolyte problem? Are you dehydrated? Things like that. If you start having worsening of your symptoms, I mean, if you're unsafe at home, you got to go to the emergency room, right? No doubt about it. If you're unsafe, if you're a danger, if you're going to get hurt, you got to go to the ER. But the ER is not a tremendous place for my patients to go. In fact, I just had a patient come back, I think it was a couple of weeks ago, right after my last talk. So my last talk, I gave apparently a good coverage of what all the bad things that happen to my patients when they end up in the hospital. And then shortly thereafter, I had a patient come to my office and said, everything you just said was exactly true. I said, of course it was. I said it. No, I'm just kidding. But at the end of the day, being in the hospital is really hard for you guys. You know, nothing good happens to my patients when they're in the hospital. You're not able to get all your medicines, especially if you're on anything not generic. Forget about it. They're not on formulary. If you're on a special version of Cinemet or a Nupro patch or something, you know, on Gentis, or you're not going to get it in the hospital. So you're not going to get the right medicines. You're not going to get your medicines on time. Who knows what you are going to get, which might make you worse. You're going to be in bed. You're not going to be getting up and moving. Not a lot good happens to my patients when they go to the hospital. And unfortunately, I would say the vast, vast majority of my patients, when they end up in the hospital, don't go back home, at least not straight away. They end up in a skilled nursing facility. They end up in an inpatient rehab at best. And then there's a lot of work to get you back home. And so this is so why I say so many times, it's so important to stay off the ground, avoid falling, avoid going to the hospital. Now, again, if it's an emergency, if you're having a problem that's life-threatening, if you're a danger to yourself or somebody else, then you need to go to the emergency room. I am by no means telling you people to stay home when you have an emergency. But if it's something that, you know, maybe is a little bit worse or a little bit new, talking to your doctor and staying out of the ER or staying out of the hospital is the best choice for you, just because again, I've just seen so many problems, and time after time after time after time after time, people come back and I hear the same stories. It's on repeat. I went to the hospital. I got my medicines late. I hallucinated. I got put on Risperdal. I couldn't move. I ended up in a nursing home. Or, you know, I'm on Rytari at home. I went to the hospital. They switched it to regular Cinemet. I fell apart. You know, I'm on Cinemet 6 times a day at home, and I take it. They only gave it to me 3 times a day at the hospital. And again, just the stories go on and on and on. You know, I try working with the hospital to see if we can get some of these things changed. I have these grand ideas in my head that with electronic health records, we can do some stuff, but it is really hard. Just take my word for it. And I am nowhere near solving the problem of what happens to my patients when they're in the hospital. And so if you can, stay out of the hospital. That was a very complicated question. That's why it took me a while to read. So are you familiar with Dr. Jonathan Sackner-Bernstein's research? Apparently I'm going to have to go read this now because I haven't heard this. That the best way to treat Parkinson's might be precisely the opposite of what would be most effective. The data in this study show that instead of focusing on increasing brain dopamine, more scientifically rational approach would be to reduce the amount of dopamine within the cells of the brain that control movement. I haven't heard that. I'm going to have to get back to you on that one. I'm glad you posted that there so I can go look at it. End of story. I'll just have to read it and get back to you next time because that doesn't logically make sense to what we think about in terms of Parkinson's disease, but maybe there's something that I can gather from what they're trying to accomplish, or maybe I can understand the rationale a little bit for you. And so remind me next time to answer this question because at the end of the day, I got to go do a little bit of reading, a little bit of, I don't want to say research, but a little bit of kind of digging, a little bit of looking into this to try to piece together what they are doing, what they're not doing. And then hopefully I can come back to you with a much better answer, or at least some logical rambling that might make sense. So good question. Let me look into it. Remind me next time because I also tend to forget everything. Remind me next time and I will comment on it next time. Why do athletes and young active people get Parkinson's? Well, boy, isn't that the $1 million question. Why does anybody get Parkinson's disease? I don't know. End of story. No, I'm just kidding. There's obviously more to that answer. But that is the long and short of it. I really don't know. We don't know why people get Parkinson's disease. And you're right. There was that catcher who played for the Rockies that I'm blanking on his name who developed Parkinson's disease. I mean, Muhammad Ali was a phenomenal athlete, got Parkinson's disease. I mean, these people exercise for a living. You know, I just told you all the benefits of exercise. Why are these people who exercise for a living getting Parkinson's disease? Why did Michael J. Fox get Parkinson's disease at 30 or before? You know, he was a fairly young, healthy, active guy.
Davis Finney.
Same idea, right? Yeah, exactly. I mean, there's all these people who seemingly do everything that I tell you to do that helps you do the best with Parkinson's disease, and then they still come down with Parkinson's disease. The long and short of it is we don't really know. We think that there is some sort of genetic predisposition, although before you get all up in arms, the vast majority of my patients do not have a family history of Parkinson's disease. Right now, we think direct genetic Parkinson's is probably only about 15% of people. And then some sort of environmental exposure. And again, we know a few, you know, Agent Orange in Vietnam, industrial strength pesticides, manganese toxicity. And again, believe me, the vast majority of my patients were not Vietnam veterans, industrial farmers, or manganese miners. So those are the ones we know or are fairly confident in, but obviously there's a lot we don't know. And probably what we don't know the most is the genetic component. So if you would have asked genetic Parkinson's disease 20 years ago, we would have said it's almost none. If you would have asked the genetic Parkinson's question about 15 years ago, we'd have said, maybe it's 5%. If you'd have asked me 5 years ago, we would have said maybe it's 10%. If you ask me today, it's about 15%. If you ask me again in 50 years, it's probably going to be more than that. And so the more we learn about the underlying genetics, the combination of genetics and environmental triggers, the closer we're going to be to trying to figure out why anybody gets Parkinson's disease. We're not there yet. Someday I hope to be. There's a lot of work trying to figure this stuff out, but that's my only guess for why these athletes or these young, healthy, active people get Parkinson's disease. My guess in their cases, they have a higher predominance of genetic component to it, just because their environment seems to be tailored towards avoiding Parkinson's disease, but I have no way to prove that. And so the answer to that question is still yet to be determined. It comes down to why anybody gets Parkinson's disease, and we're still trying to figure that out. My husband seems to be doing better on Exelon. Great, few months, more social and engaged. Success, keep up the good work. I lean significantly to one side. Can this be fixed? Maybe. I know. You guys should really be tired of my wishy-washy answers. I'm never definitive. I'm never black and white. I never give you a simple yes or no answer. This is a hard question. So Pisa syndrome, which is leaning, is a tough thing to fix. What I would say the answer to that question, this is not an uncommon thing in Parkinson's disease. It also affects other conditions. A lot of people are flexed forward, but some people do lean to the side. You tend to lean to your stiffer side, although not always. The question that I would have is, does it seem to respond to medicine? Does it fluctuate with medicines? You know, are you more upright when your medicines are kicked in, and do you lean more when your medicine is worn off? If that's the case, then I think more medicine might help with that. If that's not the case, if this is a static thing, meaning it doesn't matter what you're doing with medicines, it doesn't matter what you're doing, time of day, you're constantly leaning, then I'm less convinced that that's something that we can do a good job of fixing. There are back braces that can try to keep you upright, but at the end of the day, I can't say that I've had a tremendous amount of success with those either. The same thing is true for camptocormia, which is basically flexed in half. Another thing that if it responds to medicines or if it fluctuates throughout the day, then I think being a little bit more aggressive with medicine or treatment or therapy might be the better way to see if you can fix it. But if it's a static problem that doesn't really fluctuate or doesn't really respond, then I'm much less convinced that that's something that or anybody else is going to be all that good at fixing. Have I talked about the recent procedure, which is creating a lesion in the brain, which helps with central tremors or their side effects? Is it being done in Pittsburgh? I don't know if I've talked about it or not, but it doesn't hurt to talk about it again. So there generally is, that was a pause for effect, 2 different procedures you can do for Parkinson's disease. One is the deep brain stimulator surgery. One is what's called an ablation. So an ablation is just putting a hole in your brain. Ablations were actually invented before DBS. So we've been doing ablations for about 100, 100's probably a long time, maybe 80 years. I made that number up. Fact check me on that one if you want. But the long story short, a long time ago is we learned that if you put a hole in somebody's brain, you can stop them from shaking. We used to do it the old fashioned way. We would drill a hole in your head. We would put a probe down and either burn a hole, freeze a hole, and you would have a hole. We'd take the probe out, we'd sew you up, so on and so forth. I believe Michael J. Fox had that procedure done for his, although he's not my patient. I don't know for sure. I'm pretty sure he said he did it in his book. Fast forward to 20 years ago, somebody was doing an ablation. They found that, hey, if I stimulate, they also get better. Invention of the deep brain stimulator. When the DBS got invented, ablations kind of went away because we thought the deep brain stimulator were stimulating. This was a better plan. Fast forward a little bit, and actually we learned that, hey, I don't actually have to drill a hole into somebody's head to put a hole in their brain. And we learned that stereotactic surgery with gamma knife radiation could do the same thing. You could externally aim the beams of radiation. You could ultimately kind of, I don't want to say burn, but radiate a hole in the brain. It takes a few months to mature. It doesn't happen immediately, but it would work. They used to do a lot of those in Europe. I think we're getting away from them. Fast forward to about 5 years ago, and we learned you could do the same thing with ultrasound. So high frequency ultrasound ablation is kind of the newest topic in movement disorders from a surgical technique. And it's a new technology on an old idea. Externally, you can aim ultrasound beams to a certain area of the brain, heat up the tissue, and burn a small hole. You don't have to drill holes into the head. There's no internal machinery. And so for my patients, when I'm comparing and contrasting the two procedures, this is how I do it. To jump ahead to your last question, this is not available in Pittsburgh yet. We don't have one at Allegheny Health Network, although I keep asking, they keep telling me no. UPMC, as far as I know, does not have it either. The closest place, as far as I know, today that does high frequency ultrasound ablations is West Virginia University. So I send my patients down to Dr. Ann Murray, and she does a good job of taking care of them down there. I believe Cleveland Clinic also does it. Maryland does it. They were one of the first people to do it. And Hopkins, I think, does it. Those are kind of the near area that does them. The way that I compare and contrast these things are, so the deep brain stimulator is much more invasive. You have to have holes drilled into your head. You have wires put into your brain. You have internal machinery. Definitely more invasive. We've been doing it here in Pittsburgh for about 20 years. We have a lot of experience with it, but it's invasive. The benefits to it are you can do both sides and it's adjustable. Compare this to the ultrasound ablation or any ablation for that matter. The high frequency ultrasound ablation is much less invasive. There's no drilling into your hole. There's no drilling holes into your head. There's no internal machinery. However, currently you can only get away with one side. If you went back to the old way that we used to do a probe lesion, we learned a long time ago that if you tried to do both sides, you ended up with memory problems and balance problems. And so it's only approved today, I believe, still for essential tremor and tremor predominant Parkinson's disease for one side. And it's not adjustable. Once you put a hole in somebody's brain, maybe you can make it a little bit bigger, but at the end of the day, it's kind of a one-time and you're done thing. They are looking to see if you can get away with both sides with this new technique, but it's not published yet, it's not approved yet. And so on the one hand, you have a much more invasive surgery, but you can do both sides and it's adjustable. And on the other hand, you have a much less invasive procedure, but you can only get away with one side and it's not adjustable. And it really is individualized, picking and choosing what you think is the best thing for you. And this is the exact same conversation I have in essential tremor. It's approved for tremor predominant Parkinson's, which I haven't necessarily done a whole lot of yet. But that's kind of the long and short of it. It's worth thinking about. It's worth knowing about. It is progressing. They're working on this. They're studying this. They're improving it. But again, it is still fairly young in terms of its use and its availability. And so it's still a work in progress.
And I don't know that they've gotten insurance approval for Parkinson's yet. I think it is approved for essential tremor, but they were having a hard time getting reimbursement.
Yeah, and I haven't sent anybody for Parkinson's disease down there for it. I've sent several essential tremor. I've had several essential tremor patients get it done with good results, but I have not done it in Parkinson's disease yet. How does Parkinson's progress in those patients that take levodopa versus those that don't, either by choice or because they can't? It progresses the same. At the end of the day, we really do think that the disease progresses regardless of what we do from a medication standpoint. There was a time where we thought maybe Sinemet or carbidopa levodopa progressed it quicker, or you got used to it, or you tolerated it, or you fluctuated quicker. But really, we think that it's just the disease progressing, and it's going to progress at that rate no matter what we do. And this is exactly why we've come full circle in terms of most people, almost everybody. If you come in with a diagnosis or we think you have Parkinson's disease, almost across the board. In fact, I can think of very few instances where I wouldn't use Sinemet first. And so it really is the drug of choice first, because we don't think that it has more, it speeds up the progression to side effects, or it speeds up the progression, and it really does impact quality of life the most. And so really the progression is the same. Good. I'd love to hear Dr. Van Laar's input on that. Sorry, that was a direct message to me. She's going to ask Dr. Van Laar about that paper. Dr. Van Laar is much, much smarter than I am, so she will definitely have a better answer for that. Do they ever use stimulants or tranquilizers in Parkinson's? I use just about anything and everything I can think of to help somebody. And so, yeah, I have used stimulants. I've used methylphenidate, which is Ritalin. I've used modafinil, which is Provigil for energy. Some success, maybe. I've used it for walking in balance. There was a little bit of a report that suggested maybe the stimulants help with balance. Kind of iffy on that one. Tranquilizers. I use sleep medicines all the time. I'm not a big fan of sleep medicines, particularly what I had a psychiatrist with me all last month, and he kept referring to them as the Z drugs. I assume it was Zolpidem, which is Ambien, plus a whole bunch of other ones. But the problem that I run into with those medicines is people tend to need them. I try to stick to like melatonin, or Klonopin is the best one for REM behavior sleep disorder, which is acting out dreams. But the short answer is yes, we use all the above. I will literally use any medicine I can think of or I have ever learned about if I think it will help somebody with Parkinson's disease do better. Because as I instill in my medical students, my residents, my whoever, I'm not here to treat a disease. I'm here to treat a patient, a person. I'm trying to get you to do better. And if that means I have to hit you with Ritalin to see if I can give, then that's what I'll do. It doesn't always work, and it's not my best plan that I've ever come up with, but I'm not against trying anything. You will be tired of my wishy-washy answers at some point, and thank you for appreciating that. Perfect. Yep. I've had my esophagus stretched 3 times because of choking and the voice problems. It could just be that's how it's going to be. I mean, realistically, again, voice problems are hard to fix. If you have vocal cord changes, that can be hard to fix. Coming back to the swallowing problem. So this I like to touch base on because it's such a big issue. So the GI system, top to bottom, is impacted in Parkinson's disease. So your enteric nervous system, this is the nervous system web that controls your GI system, is huge in terms of dopamine nerve cells. This is why we think, or a lot of people think, it starts in the GI system. This is why they've been studying the GI system in your gut for a long time. This is why we talk about constipation all the time, because that's a non-motor symptom that comes before the motor symptoms. Your GI system is impacted top to bottom. And so while everybody thinks about constipation, it's not just the lower part of your GI system that's impacted or affected. It can affect your esophagus, so your swallowing can be impacted. It can affect the sphincter at the bottom of your esophagus. It can affect your stomach, both in terms of motility, but also in emptying the stomach. So people feel full quicker. They can't eat as much. It can affect the upper intestinal system and slow that down. It can definitely affect the colon system, which is where you get constipation from, and slow that down. And so the entire GI system, top to bottom, is impacted, gets affected. And most of the time it's slowing down or stopping or not functioning correctly. And so, yeah, I do have a lot of patients that have swallowing problems, choking problems, gastric emptying problems, gut motility problems, constipation problems. And these are really hard problems to fix, but they're worth investing in. They're worth seeing a GI specialist for. They're worth doing the ballooning. They're worth being on medicines to try to keep you regular, because the last thing I want, again, coming back to full circle to being key to success is staying out of the hospital. The last thing I want is an impaction to land you in the hospital when it's something we could have addressed or tried to avoid and kept you out of the hospital. And so if that's what it takes to keep you swallowing, again, I don't know what to tell you about the voice problem. Voice problems are hard to fix, but if that's what it takes to fix the swallowing problems, you keep doing it, because we certainly don't want you choking. We certainly don't want you in the hospital if we can, by all means, avoid it. Are offs and dyskinesias caused by levodopa? So those that do not take levodopa still have offs and dyskinesias. Yes and no. See, I'm getting good at this game. Offs and dyskinesias are really caused by a change in the receptors. So your brain has dopamine receptors. This is what is activated by dopamine naturally. This is what makes things work. The problem with all of the medicines, and I'm going to extrapolate what you said to more than just levodopa, because pramipexole and all the other dopamine medicines can also cause offs. They can cause fluctuations. They can cause dyskinesias. That is not a levodopa specific thing, but it is a side effect of the medicine. And so at the end of the day, if you never took a Parkinson or a dopaminergic medication, I don't think you would have motor fluctuations and dyskinesias. That is a side effect, I think, of the taking of the medications, but not just levodopa. This is true for all the drugs that we use for Parkinson's disease. And I don't think sparing levodopa by trying one of the other drugs actually prevents that from happening, or prevents it from happening quicker, or things like that. It turns out your brain does not naturally just spew out a ton of dopamine 3 times a day. That's not natural. And yet that's what we're doing by taking pills, right? So you take a pill. I usually start Cinemet 3 times a day, go up to 4 times a day, 5 times a day, whatever. You're getting like a burst of dopamine and then it wears off. That is not physiologic. That is not how that is not how our brains naturally work. And it really is that pulsatile nature, that burst of dopamine followed by the wearing off, that leads to the on-off fluctuations and the dyskinesias. Because when you get that, your brain does rewire a little bit and your receptors change. At least that's my understanding for why you end up with the side effects of these medications. It comes down to the unnatural way that I give you replacement dopamine. And so one way that I think we are aware of this is it turns out that levodopa comes in an intestinal gel called duopa. So basically this is, you get a tube put in and you have a pump, and it pumps levodopa into your small intestines for about 18 hours throughout the day. Again, invasive, not exactly convenient. I've used it a few times. I've had some success with it, but obviously not my first go-to. But it turns out if you administer levodopa that way, you avoid the dyskinesias and the on-off fluctuations and the side effects of the pills. And again, it's because you are not getting that burst of dopamine followed by the wearing off. You're getting a steady state of dopamine by directly infusing it into the small intestines. And that is still probably not natural. I mean, I don't think our brains naturally just put out a certain amount of dopamine 24/7, but probably more natural than the pills. Again, there is nothing natural about a burst of dopamine from a pill followed by a wearing off. And that is directly, we think, what leads to the side effects and the complications and the dyskinesias and the on-offs and things of that nature. And so, again, I think I covered your question, but it's not specifically levodopa that does it. And at the end of the day, it comes down to the unnatural way that we're treating you. But it's still realistically the easiest or theoretically best way to treat you, because jumping straight to an infusion or a tube and a pump, maybe not the best first choice. Yeah, and so coming back to the choking question, a lot of my patients have to have to think to swallow correctly. You really have to concentrate and put a lot of effort into it. And this is what they use and expound upon in speech therapy, right? They teach you tips and tricks, and you have to pay attention, and you tuck your chin and use a straw and all the stuff that speech therapists know a whole lot better than I do. But this is true. You really do have to put a lot of brain power and energy into it. And again, this is fatiguing and tiring. And so at the end of the day, I'm not surprised by that. And then can esophageal spasms be related to Parkinson's disease? It's not something I see commonly. I've had a few patients who have really had esophageal spasms. You actually get esophageal spasms more in multiple systems atrophy, which is a Parkinson's disease plus condition, more so than a typical Parkinson's disease, but you can get it. You can get a lot of esophageal issues in Parkinson's disease. It can be affected just like everything else can be, and it is a challenging thing to try to work on. So I would say the answer to that question is I think it probably can be part of Parkinson's disease, although it's not something that I see commonly. And so I would just bring it up and have it addressed. And with that, believe it or not, David might have run away. Christine's still there. Casey might still be around. I actually ended with all the questions right on time. Has that ever happened?
I don't know.
I don't think that's ever happened.
Well, after 2 years, you are the pro.
You think I would be better at this?
The way you were talking about your waffling on answers, I was getting ready to maybe terminate you, but I don't know.
Do I get a vacation out of it if you terminate me? Because I might take it at this point.
Well, you'd have to go on unemployment, I think. And you know what a nightmare that is.
Oh, I hear about it. Don't worry. All right. Well, David, I'm glad you were able to make it with us. And again, happy 6 years of us working together. This has been a fun time. Again, hopefully everybody learned something. As long as you guys keep having questions, I'll keep doing it. If we ever get to the point where there's absolutely no questions, then that's when I'll throw in the towel, but I don't think that's going to happen anytime soon. So on behalf of everybody, thanks for showing up. And I guess we'll do it again the first Thursday of April, whenever that is.
See you
Somebody
April
will remind me.
7th, right before our conference, which is on April 10th.
As long as somebody sends me a reminder, we'll be good to go.
We will.
Right.
Thank you,
All right.
Dr. Licklider.
Thank you.
Yeah,
Have a
thank
good night,
you.
everybody.
And I'll see you tomorrow.
I'll be there.
I will too.
Bye, guys.
Bye-bye. Thank you.